Great, thank you so much, and welcome everyone. My name is Gary Blau. I am the Chief of the Child, Adolescent, and Family Branch at SAMHSA, the Substance Abuse and Mental Health Services Administration, and we are incredibly pleased today to be able to present this particular webinar related to clinical high risk for psychosis and early first episode, and to have with us an amazing presenter and an international expert on the field. Before we get to Dr. Heinssen, I do want to go through a few things with some folks and remind people and participants that there's a lot of history, resources, information out there that you can access in order to assist in your efforts to develop and implement services in this sphere. I wanted to start by reminding people that SAMHSA has been involved for quite some time with this through our mental health block grant and the 10% set aside. And so more information if you would like to know more about programs are available to you. And for us, though, that as we got more involved with doing this work around the first episode of psychosis, it became pretty clear that we also needed to do some work around the clinical high risk or the prodromal phase. And fortunately, we were given permission to do that through the passage of the 21st Century Cures Act, amongst about 948 pages of additional service and language. They had a paragraph related to our work in children's mental health and systems of care. In particular, this act authorized that SAMHSA could use about up to 10% of the Children's Mental Health Initiative, or our Systems of Care program, to set that aside specifically to provide a program related to youth and young adults at clinical high risk for psychosis. We also did some extended the system of care age from up to 21 through 21, and then level funding, although we actually have had a funding increase in the last couple of years in that program, up to $125 million, which means that we can spend at least up to about $12.5 million minus rescissions and taps and things that happen in the federal government to help fund the way in which we operate, but about $12 million or so towards this program, and that was what I think was really good. And the program itself operates using the system of care framework, this approach. So as a quick reminder, a system of care being a spectrum of effective community-based services and supports for youth and young adults who are at risk for mental health or other substance use challenges in their families, coordinated network, partnerships with young people and families themselves, addressing cultural and linguistic needs. So essentially, I think the importance here is that we've connected the dots between what's going on in systems of care, because that program has had a national evaluation for many years that demonstrates that it works. And that approach, coupled with the work that's happening in the world of clinical high risk that you'll hear Dr. Hansen talk about, really does blend well together. And so it's something that we've been doing. And our colleagues that have been on the phone and are being presenters, Patty and Tamara, and folks that have been working in this space at Stanford and PepNet, et cetera, all got together and actually created this monograph or issue brief related to integrating early psychosis into the system of care framework. If we can provide a link for that, and folks can share that information. It really does give people a foundation about the connection here between our work in systems of care and the work that's being accomplished in the clinical high risk space. And as you saw from the 21st Century Cures Act, we can award grants. And this last year, 2018, issued a funding announcement. And these are the grantees. We now have 21 grantees across the country that have been awarded up to $400,000 to implement this clinical high risk program. So we're very excited and proud. We also want to remind all of our folks that are out there, be you a grantee or not, that Several years ago, CMS worked with SAMHSA and NIMH to come together to create a joint informational bulletin about coverage of early intervention services for first episode psychosis. And that informational bulletin can provide help and assistance, at least, to try to get services reimbursed and financing structures in place for this work. We've also had a long-term connection with our colleagues at the National Association of State Mental Health Program Directors, NASHPD, and the NASHPD Research Institute and their technical assistance activities. And I put this slide up with the website address as a resource because NASHPD, on behalf of the work that we were doing in first episode and certainly in clinical high risk, helped SAMHSA and create a host of resources that are at that website, anything from issues related to school-based services to what's happening in lessons learned in the field. So I really recommend, again, that part of what we do here is provide information and then let our folks out in the field use that to your advantage as you're developing and implementing programs. In addition, one of the things that we're doing through my branch and our work with the Technical Assistance Network at the University of Maryland, which is our TA Center arm related to our work in systems of care and through these programs, et cetera, and from legislation that was also passed, we are able to provide TA not only to grantees, but to everyone around the country around these various topic areas. And we are now so today actually is an important day for us because this marks a significant expansion and an extension of our work from in essence, from the work around first episode psychosis and clinical high risk into a broader learning community that we're establishing. And this is really our kickoff. And the learning community is going to extend into peer-to-peer kinds of things. There'll be a learning management system. And so you can see at the bottom here the TA telegram. And if you're interested in getting more information on updates, as I think it was Tamara was writing before, the next webisode or webinar that we're going to be doing, to subscribe to the TA telegram at that particular address. So ultimately, I think that our role is to try to assist you all in doing this and to try to get the best information and lessons learned that we possibly can. SAMHSA's mission is to reduce this impact of substance abuse and mental illness on America's communities, and we take that very seriously. And with that, let me just say that it is my personal honor. I am so proud to be able to introduce to you today our featured speaker, Dr. Robert Hansen, who is the Division Director for the Division of Services and Intervention Research at the National Institute of Mental Health. As a board-certified licensed clinical psychologist, Bob has had experiences as both a practitioner and a scientist at NIMH. He was the science officer for the groundbreaking studies related to the North American Prodrome Longitudinal Study, NAPLES, as well as the recovery after an initial schizophrenia episode, the RAISE initiative. He has so many commendations, an amazing person who has been a real important in this field, and we are proud to have him as a partner in all of these activities, and we appreciate him very much. So, ladies and gentlemen, I'm introducing Dr. Robert Hansen.
Gary, thank you very much for that very warm welcome. It's a pleasure to be collaborating with you again, and thank you for the invitation to address the learning community. So I wanted to start by congratulating all of the new clinics that are supported by SAMHSA's Clinical High Risk for Psychosis Service Grant Program. I think it's terrific that we're seeing an expansion of these services in community settings throughout the United States. So I want to welcome all of you, and again, congratulations. And at the same time, also want to welcome others who have been working in this area for quite some time and have been paving the way for better care for people with early serious mental illness. So thank you all for participating today. So to start off, these are my disclosures, and you can download the slides and read this, so I won't spend any time on this. The outline for today is here. What I would like to do is to start by putting us all at the same starting place and begin with a description of the clinical high-risk paradigm for psychosis, and then to walk you through a selective overview of clinical high-risk research. This research now spans 25 years and several hundreds of scientific publications, so in the interest of time, I'm going to have to be selective and cover some things from a very broad perspective, but I would like to drill down on a couple of topics, one of them being the science-to-service research opportunities that are making themselves present and could be of great interest to those of you who have started new programs under the CHRP initiative, and particularly the opportunities for your collaborating with researchers to adapt research-based tools for understanding ways to stratify clinical high-risk populations for the purpose of more tailored treatment, and then opportunities for developing and testing step care interventions. And then finally, I'm going to make you aware of some National Institute of Mental Health priorities for practice-based research in community-based programs for clinical high risk, and also point you in the direction of some funding opportunity announcements that we have that would support that research. So that's the overview. So to talk a little bit about the clinical high-risk paradigm. So if we take a step back in time, about 30 years, around that period, first episode schizophrenia was an area of intense scientific interest. Clinical researchers at that time were looking at the first episode of psychosis, the beginning phase of schizophrenia, as really being a tremendous opportunity to study the brain of people who have schizophrenia before the introduction of antipsychotic medications that could presumably change neural operations, neural functioning, and also a time early in illness before the impact of different experiences, life experiences, created the kind of chronic impairment that we know is so damaging to people with serious mental illness. So there were many, many studies that were looking at studying the first episode of schizophrenia, the first episode of psychosis, and looking at how the course of illness was affected by just what the course of illness was from the first episode forward. There were some astute clinicians who were part of that research enterprise who observed that the people who were coming into these research programs often reported experiences that indicated that the onset of psychosis is often preceded by a decline in behavioral functioning and the appearance of unusual thoughts and perceptions, and that sometimes these unusual experiences were occurring weeks or months, sometimes years before the onset of psychosis. So this became known as the prodromal phase of schizophrenia, the pre-symptomatic phase, and it in itself became a topic of tremendous scientific interest. If you're interested in an overview, a historical overview and a state-of-the-art review of clinical high-risk research, this is a great paper by Paolo Fusar-Poli and colleagues. It's a little dated, came out in 2013, but I want to point out a couple things about this paper that make it very notable. First is, if you look at that author list, it's a veritable who's who of the international early psychosis research and clinical community. So it was amazing that this number of scientists and practitioners were able to get together and to achieve such a high degree of consensus as they synthesized what we know about clinical high-risk states and how they move into active illness. The other thing that's notable here is that figure indicates that there has been an explosion of scientific research in this area since the earliest days in the early 1990s. Now this figure ends with studies that were published in 2011, so we have an additional 7 years worth of experience. And I can tell you, just as somebody who monitors the literature, this accelerating growth has not slowed down. So this is an area of tremendous scientific activity, and it remains so and will be for some time to come. These bullets give you an idea of some of the domains of research that are covered in this review paper. So it really does give you a very nice overview. I'll point out that the work that underpins this review was primarily conducted in research clinics that were associated with academic research programs in early psychosis. The question today for this particular webinar is what tools and strategies that were developed in these laboratories are relevant for clinical practice today. How many of them are ready for implementation in real-world practice settings, and what would we need to understand to be able to adapt them for routine clinical use? So for all of these items highlighted in red, I'm going to speak about them a little bit from this translational and implementation perspective. Biomarker studies, although tremendously important, are probably a bit upstream of the kinds of practice-based research that you may be able to achieve in your community clinics. So I'm not going to talk about that in depth today. But let's start with discussing the clinical high-risk criteria. So the clinical high-risk syndrome captures a population of individuals who are at imminent risk for psychosis onset. Now these different categories of risk were outlined for the first time by Alison Jung and her colleagues in Australia in the early 1990s. And they were doing this in the context of first episode psychosis research and based on recollections of individuals who were enrolled in the first episode psychosis program. These clinical researchers began to notice that there were various pathways through which people, most of the people in their first episode psychosis program would pass on the way to psychosis onset. So these different areas, someone having attenuated psychotic symptoms, so unusual thoughts or perceptual experiences that become increasingly bothersome over time, or having become bothersome but do not cross the threshold of a psychotic level of intensity or impairment. In contrast to people who have brief, time-limited psychotic episodes. So they actually do experience episodes of psychosis, but they don't last long enough or occur frequently enough to be classified as a first episode of psychosis according to current diagnostic manuals. There was a third group of individuals at that time were labeled genetic risk and recent deterioration. And genetic risk here meant individuals who had a first-degree relative with a psychotic disorder or individuals who met criteria for schizotypal personality disorder. They were felt to have some trait vulnerability. And then in the context of a recent deterioration of functioning, they would represent a group at risk for developing psychosis. So that kind of framework really led to work to operationalize the criteria that would capture the essential clinical features of each of these syndromes of clinical high risk. And again, here, the first work in this area was done by Alison Young and the Australians, who created the Comprehensive Assessment of At-Risk Mental States. And then in the United States, their work was carried forward by Thomas McGlashan, Scott Woods, and Tandy Miller, who developed the structured interview for prodromal risk syndromes, which gave us the ability to reliably rate the severity of different clinical high-risk symptoms and to monitor them longitudinally over time. So these two measures, the CARMS and the SIPs, are the most frequently used instruments in the English-speaking countries to identify people who are at risk for psychosis, and they really have had a tremendous influence in the field, giving us a framework for being able to identify cases, to be able to follow them longitudinally and rate their clinical progress over time, and create a picture of what this risk state looks like from initial onset through several years going forward. I will mention that there are other criteria for identifying prodromal symptoms. The German researchers, following their tradition of basic symptoms, have developed a number of tools that get at very subtle differences in cognition that often precede the development of functional difficulties and then symptoms. And in Europe and many research settings, those instruments are also used to identify people in the earliest phases of clinical high risk, but those instruments are probably a bit out of range for the kind of programs that all of you are working in, so I'm not going to refer to them from this point forward. So those operational risk criteria have given us the ability to follow cohorts of individuals who are at clinical risk over time and to look at the outcomes that they experience. So a couple of things about this slide. First, it's from the overview and synthesis conducted by Fuzar Poli and colleagues in 2013. They looked at 7 longitudinal studies that identified individuals who met criteria for clinical high risk, either through the CARMS or through the SIPs, followed them prospectively for 2 years or more, and monitored the rates of transition to psychosis within those groups, as well as other clinical features. The first thing, when you look at the figure, the first thing you can see is there's considerable variability in the transition rates reported by these studies. The summary of those studies you can see in that black line in the figure, and that indicates that on average the transition rates to full psychosis among people in these categories are approximately 15% after 1 year and 25% by 2 years. Now, since 2013, there's additional research, additional cohorts that have reported that these rates of transition appear to be dropping, so they may be a little bit less than the figures that we're seeing here. But even with lower rates of transition, the risk of developing a psychosis for individuals within the clinical high-risk groups is tremendously greater than people from the general population who do not meet the risk criteria. So that it's still picking up a phenomena of great clinical interest. The second thing that I'd like to point out is that in terms of diagnostic outcomes for people who do convert to psychosis, not surprisingly, the vast majority of them go on to a schizophrenia spectrum disorder. I say not surprisingly because the risk criteria were originally developed to identify people who were at risk for schizophrenia, so they do a pretty good job of picking up among people who develop psychosis who will go on to schizophrenia, although it's not a universal outcome for people with who experience a first episode of psychosis. About 8 years ago, researchers began to pay attention to outcomes among the people who do not convert to psychosis. And Jean Addington and her colleagues were the first to conduct this work and have followed it through, and it's been picked up in other centers. But these figures come from an analysis of the experience of participants in the North American Prodrome longitudinal study, as described in a 2018 publication by Jean and her colleagues. And here we can see that a little bit more than a quarter of those individuals, while they do not go on to experience psychosis, they continue to experience symptoms that are right at the cusp of psychosis. So attenuated psychotic symptoms that don't cross the threshold, but are still in the moderate to moderate severe or severe level and have an impact on functioning. About a third of these individuals no longer meet clinical high-risk criteria, so their attenuated psychotic symptoms get better. But in these individuals, they remain symptomatic. So depression, anxiety, distress, other comorbidities are common among this group, and as well as functional impairment. Jean's study reports that about 40% achieve remission from clinical high-risk criteria, and what might make you think that, like, well, that's pretty good. That's a large number of these people who go on to achieve remission. But they're doing work now to understand that particular group more. Ty Cannon, in a personal communication, recently told me that it's really only about 10 to 12% of the individuals in the sample that achieve an early and enduring remission of symptoms and go on to a positive outcome in terms of remission of positive symptoms and normal functioning capacity. So what we're seeing in these data are that, well, first of all, that the clinical high-risk syndrome, it's not a uniform entity. There's a lot of heterogeneity in clinical presentation. So there's depression, there's anxiety, substance abuse, functional difficulties in terms of social functioning, academic functioning, work functioning. So there's a lot of heterogeneity in the clinical presentation. These data are showing us that there's heterogeneity in the course and also the outcomes of clinical high risk. So although originally these criteria were developed to identify people at imminent risk for psychosis, we're actually seeing that there's a lot of heterogeneity, but this does not undercut the importance of the clinical high-risk syndrome. It's a meaningful clinical entity. These individuals experience a considerable degree of distress, of dysfunction, they're help-seeking, and in many cases, the outcomes are suggesting to us that they represent the earliest stages of serious mental illness. So I want to point out Alison Young's study in 2004 from Australia. Just note that date, because while Alison was collecting the date on what the long-term trajectories of these individuals were, her colleague Patrick McGrory was already beginning to lay out a rationale for indicated prevention studies to prevent the onset of psychosis among clinical high-risk individuals. So Pat started writing about this in 1998, and he's been at it now for over 25 years, advocating for science that would address the question of indicated prevention. So Pat wrote this article in 1998, and within 4 years, the first randomized controlled trial of interventions that were designed to reduce the risk of progression of first episode psychosis appeared in the Archives of General Psychiatry. It was soon followed by, so that was from the Australian group. It was followed quickly by a study from the investigators in the United Kingdom who studied cognitive therapy for the prevention of psychosis in people at ultra high risk. and then a third study in 2006 by Tom McGlashan and the group at Yale that in a randomized double-blind trial of olanzapine versus placebo looked at transition to psychosis among people who met clinical high-risk criteria. These three studies were very promising in that they showed that it was possible to reduce rates of transition to psychosis. It was possible to decrease the severity of attenuated psychotic symptoms. So the first three studies were giving us a signal that we could intervene in ways that were meaningful for people with clinical high risk. So those were the first three studies. There were then kind of a series of studies that followed. And of course, when you have a series of clinical trials, it becomes fashionable to pool them and in a systematic way meta-analyze the results to see if there's an overall effect. There were three early meta-analyses that looked at very small samples. Between 2010 and 2012, there actually were three of them. All of them were fairly powerful in terms of supporting intervention in clinical high risk. The first one that got into the double digits as far as number of trials that were looked at was a study conducted by Megan Stafford and her colleagues. And in this meta-analysis of 11 randomized controlled trials, she was cautious about the evidence for being able to prevent onset of psychosis. She concluded that the findings were suggestive that it might be possible to delay or prevent transition to psychosis. And in that meta-analysis, she pointed out that cognitive behavioral therapies appeared to be particularly promising, both for their ability to reduce rates of transition to psychosis, but also because they had value for some of the comorbidities that people brought with them with regards to depression, anxiety, and so forth. That meta-analysis was followed by a second in 2013 by Mark Vandergaag and colleagues. This one was a little bit more supportive of the idea that early interventions could be successful in preventing or delaying onset of psychosis. So by 2013, we had two meta-analyses, and Vandergaag and Stafford independently analyzed a very similar set of studies. So the fact that two sets of independent evaluations came together in a consistent set of findings was gave us some confidence that the field was on the right track. Just last year, a somewhat contrary view appeared in a meta-analysis conducted by Kathy Davies and her colleagues. This appeared last July, and a much larger set of randomized controlled trials, 16, and almost double the number of patients in the meta-analysis as compared to the earlier systematic reviews. And this one was sobering. The results of the network meta-analysis suggested that while there appeared to be some effective interventions that had value, clinical value for this group, there wasn't evidence to favor any specific intervention over the others. So this is a meta-analysis that bears a lot of study and understanding because they try to, and particularly the way that they unpack the negative findings that they report and the suggestions that they make for what the next set of research studies might be that would be informative about prevention in clinical high risk. So not surprisingly, all three of these meta-analyses conclude by saying that further research is needed. So there actually is a fair amount of concordance between the three meta-analyses on what kind of avenues for research could be pursued. And in this slide, I just emphasize some of the specific points that these studies make. So Stafford recommends trials that combine family and individual CBT, and that because noting that family members are also affected when people develop clinical high-risk features, and that including them in the treatment is consistent with treatments for first episode psychosis, could have benefits for family members and could also benefit the person with clinical high risk. Vandergag was the first person to make the point that perhaps we're overemphasizing onset of psychosis as a key outcome for these studies, and that by doing so, we're missing out on developing treatments that address comorbidities such as depression, anxiety, and impaired functioning. And then he made the suggestion that for those who want to go after psychosis onset, we probably need enrichment strategies to identify those people who are most at risk and then develop interventions that are specific to them, because preventing psychosis in those people who are at greatest risk, that treatment will probably look different than people at lower levels of risk who are primarily suffering with anxiety, depression, and that type of distress. Davies and colleagues were very specific in saying that future research should stratify clinical high-risk groups into more homogeneous subtypes and then test interventions that target underlying mechanisms. So here, she's beginning to move in the direction of trials that would fit within a stepped care framework, where populations are broken down into subgroups, interventions are targeted at essential characteristics that define those subgroups, and that empirical study gives us ideas about, better ideas about how to understand the underlying vulnerability within those subgroups. So we agree at NIMH with these research studies that more research is needed. The question is, what kind of research should we be supporting? And most specifically to this group meaning you, who are involved in community-based care for clinical high risk, what kind of research might make sense in community settings and research that is pursued under a practice-based framework? So looking at those meta-analyses and other publications in this area, there are a couple of directions that have been identified, and I've mentioned some of these already. Stratifying clinical high-risk samples. We know that within those samples that people vary in terms of the degree of risk that they possess for developing psychosis over a short time frame. So identifying those people who are at the greatest risk may be one way of identifying an at-risk group that is more homogeneous and that might suggest a targeted, aggressive strategy to interrupt the processes that are going to lead to psychosis onset. It would also be great if we had tools that would be able to identify that subgroup of individuals that I mentioned earlier that have a fairly high likelihood of achieving early and enduring recovery. If we were able to stratify samples in that way, you could imagine that treatment approaches would be very different for those groups, and then for those who fall in between, we would have other strategies. Mechanistic models of clinical high risk would take us in the direction of exploring biological and psychological mechanisms that underpin the clinical high risk syndrome, and then targeted interventions that might be able to disrupt those mechanisms or repair them so that the person returns to a normal trajectory. And then finally, as Mark Vandergag recommended, to begin looking at outcomes beyond psychosis and to take seriously the clinical distress that these young people are presenting with and the functional difficulties that they experience. So those are the directions. And what might be the strategies? Well, strategies for stratification might include individualized risk calculators that use a combination of clinical data, demographic data, and other data in multivariate statistical analyses to develop tools that allow us to predict with greater accuracy who would fall into these various subgroups. Currently and in the future, we can look at multimodal machine learning that would not only look at clinical data, demographic data, but integrate results from imaging studies, from neurobiological assays, and so forth to develop perhaps more sensitive tools for stratifying samples. Within mechanistic models of clinical high risk, biomarker discovery studies, experimental therapeutics, randomized controlled trials would be acceptable strategies. And then finally, for outcomes beyond psychosis, step care interventions might be an approach that would be valuable. Now, given the audience and given the time, I'm going to spend a little bit of time just talking about risk calculators and step care interventions and their relevance to those of you who are now working in community programs that follow a step care framework and utilize standardized tools such as the structured interview for prodromal risk syndromes as a unifying framework for conducting your work. So to talk about individualized risk calculators, this slide summarizes work that was done in the North American prodromal longitudinal study where 596 help-seeking individuals at clinical high risk were followed for up to 2 years. 84 of those individuals transitioned to psychosis, so that gives us an adjusted transition rate of 16% at 2 years. And the Naples investigators collaborated with a decision scientist from the Cleveland Clinic, Michael Catan, and who's an expert in developing medical decision tools in areas like heart disease, cancer, other medical conditions. And he worked with the Naples investigators to follow strategies in decision science that help develop those medical decision-making tools. I'm not going to go into all of that, but the result of this was they came up with a model where 8 variables really contributed to increasing the accuracy of predicting psychosis onset among this clinical high-risk group. The area under the curve for this model was 0.71, which actually that tells you that your test is operating pretty well. It's doing a pretty good job of distinguishing people who have outcomes of interest to you. And that AUC of 0.71 is actually comparable to what we see in other areas of medicine. So we're doing as well as many screening instruments in heart disease and cancer. An interesting aspect of this study is that with this paper in American Journal of Psychiatry appeared another paper from Ricardo Carrion and his colleagues where they applied the Naples risk calculator to another sample, an independent sample of individuals at clinical high risk, and they found that actually the model not only performed as well, it actually performed a bit better in being able to distinguish those who converted from those who did not. So this gives us the idea that we can use variables that are collected in typical care to create a risk calculator that gives us some ability to quantify the amount of risk that a person possesses for developing psychosis over a 2-year period. So just notice that under the predictor variables, we're talking here about clinical items from the SIPs. Here, the items relating to unusual thought content and suspiciousness add to the model. We're looking at decline in social functioning as it's measured by the global functioning scale. We're talking about 2 measures from neuropsychological test batteries, age, stressful life events, family history of psychosis, and the number of traumas that a person experienced. So these are things that we could conceive of collecting in a clinical program. So it makes it attractive to think whether this calculator would be able to be used in clinical programs. So to walk you through some of the issues about that kind of implementation, first, the calculator appears as a tool in the library of risk calculators that's maintained by the Department of Quantitative Health Sciences at the Cleveland Clinic. That's where Michael Catan works. And if you clicked on that link, it would take you to the Naples Risk Calculator. And what you would see is you actually, this one slide represents two separate pages. The first page that you would come to is it would describe the calculator, and it would ask you to confirm that the person that you're interested in evaluating for risk, level of risk, that person has had an interview-based SIPS diagnosis of prodromal risk. And secondly, it asks were the ratings obtained by a professional. Now, there's no way that the website knows whether the person working with the calculator is telling the truth, but it does signal that the calculator is based on a sample of people who were ascertained by the SIPS interview, where raters were highly trained to achieve reliability and to maintain it over time, and that other measures, and that pertained also to other measures in the calculator, the neuropsychological variables, the other clinical variables, and so forth. So what you see here is that if you get to the second page, if you answer yes to those things, you'll get to the second page. And on the left, there's that's the actual calculator, and you can move the slide bars to fill in the information for the individual you're interested in. And on the right-hand side, their probability of converting to psychosis at 1 year and 2 years will appear both in terms of the absolute number and in the figure as the portion of a pie chart. Now, you can imagine that in a treatment program or even in a clinical trial, you could use this calculator to select individuals who are above a certain risk threshold for preventive intervention, either as a clinical treatment or as an arm in a clinical trial. This particular individual here, we're seeing a risk of about 32% at 1 year and about 40% at 2 years. So when we think that the 2-year transition rate that was reported by Fusar-Poli was around 25%, this person is higher than that, so they're in the higher category. But both a clinician and an investigator could set a threshold, maybe 50% chance, saying that that's high enough that we think that we'll get enough events to be able to conduct a scientific study of an intervention that is targeting psychosis onset. I sometimes imagine that what an advantage it would be if we had a similar type of calculator that would be able to identify the people who are likely to be early responders. And you might imagine that the treatment approach would be very, very different for a group that was at high risk for developing psychosis over a short time frame versus those people who are at high likelihood of having an early and complete recovery. So that's what the calculator looks like. What are some of the implementation issues of going from these research-based approaches into the clinic? Well, I've listed a few here. The main issue is about the reliability of the data collection. In the research studies, interviewers have achieved a high level of reliability on the overall SIPS process, and they're also achieving reliability on ratings of particular items that go into the risk calculator, unusual thought content and suspiciousness. What does it take to be able to achieve that reliability in non-research programs? And that can be asked of each. I won't go through each of these bullets, but the essential point is how can we be certain or confident that the level of accuracy in identifying individuals and rating their symptoms and rating the items that go into the risk calculator are comparable to those in other studies. And just to draw that point out a little bit, I want to remind us that it's not a trivial matter to make these distinctions about what's an attenuated psychotic symptom. In this slide, you see that it compares two items, or compares an item that gets at delusional thinking. On the left, from the positive and negative syndrome scale, which is generally used for people who already have psychosis, and on the right, the unusual thought content item from the SIPS. You can see that for the PANS, that rating of 2 would translate into somebody who has minimal or a questionable degree of, either they have a minimal psychotic process or it's questionable whether there's psychosis present in their thinking. The SIPS takes that same space of minimal or questionable on the PANS, and it subdivides it into 5 ratings, 3 of which relate to clinical high-risk state. These are very subtle distinctions that are made on the basis of interview probes and rating the meaning of the verbal content. It's not an easy thing to do. So it's not a trivial matter. But I don't think it's something that stops us dead in our tracks. I mean, we can ask, there's a research agenda here about, well, how do we take what we know about both making the diagnosis of clinical high risk and gathering the information that goes into the risk calculator, and how do we make that work in community clinic settings? So this becomes an implementation research question. Is it effective to use local training and ongoing monitoring? Alternately, online learning platforms, is that a way of doing it? Using remote centralized raters, as was the case in the RAISE early treatment program study. Those are all strategies that might be considered that could be implementable in clinics, and research to show how that would be the case. There's also the possibility of research that maybe goes a little bit more into the future. So, for example, applying artificial intelligence for medical diagnostics to provide tools that diagnosticians can use that prompt them to ask the right questions, to elicit the right information that would make it possible to evaluate the person's risk status. And then other possibilities are maybe even going beyond that, and as Cheryl Corcoran did in New York several years ago, doing language analysis to identify disturbances or aberrations in the content and structure of the verbal productions of people with clinical high risk, to identify those most likely to convert. I see that I have a few more slides. I'm going to pick up the pace so I don't take up all our time, and move from risk stratification into step care models. So here I found a very nice schematic of the step care approach from a article in early 2000 that was describing step care for addiction disorders. But essentially, this lays out what the framework is for step care. First-line interventions are selected on the basis of a person's continuum along along a continuum of illness risk or symptom severity. They're assigned to a treatment, and then their clinical progress is monitored against predetermined criteria, either for recovery or for worsening or lack of improvement. and changes in therapy, either stepping up the intensity of treatment or stepping down, depend on the outcomes that are attained with earlier interventions. So it's a process that involves a fair degree of measurement-based care, and being able to match people to the interventions that match their level of illness severity. So applied to clinical high risk, and I'm sure that all of you struggled with this as you were responding to the SAMHSA announcement. What's the appropriate framework for assigning clinical high risk patients to initial care? As I was talking before, in the meta-analyses, is it by psychosis risk status, or is it by whether the person is presenting with distress, comorbid features, or functional impairments? That's an important starting point. Once you have figured out that framework, it becomes necessary to define outcomes a priori for each of these starting points, and having some internal or having some consistency and reliability within your program about what it means to have clinically meaningful improvement, or how do you determine whether the person has stable but persistent clinical high-risk features, or that there's a worsening of CHR symptoms or functional difficulties. And then if you have that kind of measurement in place, what are the decision rules for maintaining, increasing, or decreasing the intensity of the treatment? Now, I lost my thread. Oh, here's my thread. The thread was, we think that these things are not a reason not to go forward, but these are things that suggest that more could be known, and the fact that you are now offering care for clinical high-risk individuals in community settings offers an opportunity for practice-based studies that leverage partnerships between SAMHSA grant recipients for the CHRP program and others in the country that are doing this kind of work outside of academic research centers, that we might create, or you might create, new partnerships between those groups and mental health researchers. And that together, those teams could think about research that would advance diagnosis, risk assessment, and indicated prevention for people at clinical high risk for psychosis. So last December, that's actually just a month ago, NIMH published this notice of interest that listed our priorities for research to inform step care interventions for persons at clinical high risk for psychosis. So this was targeted exactly to your community, community mental health settings that might ally themselves with mental health researchers and take on some of the implementation questions that I outlined today. So we had a long list of studies that we were encouraging, 3 that map on to things that I was talking about in this talk. Research, adapting research-based diagnostic assessments and risk stratification tools for practical application in community treatment settings. There's an applied research agenda there that would be very important to pursue. Launching trials that test interventions of varying complexity, intensity, and duration that target clinical high-risk symptoms, functional impairments, and also comorbidities. And then as those trials are being done, looking at what would be predictors of individual treatment response at each stage of care, and using that to inform subsequent studies or subsequent approaches to the personalization of clinical high-risk interventions. I also want to mention, although it's not on this slide, the announcement does allow for, if there are clinics that actually are allied with research centers that have the capacity to do multimodal biomarker studies using individuals in the community programs. And what do I mean by that? Multimodal biomarker studies might include things like the data that are collected for the risk calculator, combining them with with data from imaging studies, from electrophysiology studies, from studies that are using things like the polygene risk score for psychotic disorders. We would welcome those kinds of suggestions as well. The person to talk to is my colleague, Dr. Susan Azrin, who's the scientific contact for this particular initiative, and she will direct you to the program officer who is most likely to be able to be helpful to you and think through your research program. So that brings me to the end of my talk. Gary, I'm sorry I went a little bit longer than I said, but I'll stop here, and I see that we still have some time for questions and dialogue. If that's of interest to people, I'll be available right through 2:30.
Now that's great, Bob. No problems on my end. Tremendous information and content here. And one of the questions that I saw that we had here, it looks like from Nadia, is has the risk calculator had any tests longitudinally? I don't know if you got to that one.
So the data that went into it were data that were collected from people who were followed longitudinally. It was published for the first time just a few years ago. I know that there are other groups that are utilizing the risk calculator to explore how it can be, well, to explore its utility with other samples. So that's all I can say.
Yeah, no problem. I think that answered the question. Thank you very much. I would just offer to, if any folks are interested, to go ahead, or if we've had other questions that I'm not aware of, to maybe Tamara or Kate, you guys could identify them for us, and then we can pose those questions. So this is a great time for folks to ask questions of Dr. Heinssen.
Okay, here, this is Tamara. So there are a couple of others that have come up through the course of the webinar. One of those relates to the original conversation about the transition. So the question was about whether in the studies around the percentage that were transitioning, were people receiving interventions? And then kind of a related question is whether there are longitudinal studies on the SIPs that look at more at a 10-year time frame.
So I guess the first question is about, asks about this declining rates of transition in studies over time, and whether that could be because people who were followed were getting better care. That is one possible explanation. I think in the earliest studies, the ideas about how to best care for these individuals were very early in their development, and it's possible that people were getting into the clinical programs closer to the threshold of psychosis, and maybe the interventions weren't as well tailored, and it's possible that now people are coming into programs earlier in the stage of clinical risk, and for those people who were in an earlier stage, it may be that the degree of monitoring and needs-based intervention that they get might have some positive impact on their risk status. That's one possible explanation. There are others that are being debated in the field. So many hypotheses that are being investigated, but all of them are trying to understand, which is a fairly consistent finding, that the rates of transition have been declining over time. But that being said, I hope I made the point convincingly that even if the rates of transitioning to psychosis have been declining, the amount of the severity of impairment within this cohort is sufficient enough to tell us that this is a syndrome of great clinical interest and deserving of our full attention. Then, Tamara, the question was whether the SIPS has been used to study people for 10 years or longer. You know, I don't know the answer to that. Just scanning the chat box, I see that Dr. Scott Woods from Yale is listening. And Scott, I don't know whether you could address that question, whether the SIPS has been used in any study for up to a 10-year time frame. And maybe we can move on to the next question to give Scott an opportunity to type in an answer.
That's great. Also, I think this one might also be one that Scott might be chiming in on, which is related to the olanzapine study. I know that there was a statistically significant positive finding, but the recommendations generally are to avoid antipsychotic use, except right at the point of transition or close to it. So I'm wondering if somebody could kind of weigh in on that.
Well, I think so. In each of the meta-analyses, they've concluded that as a preventive treatment, antipsychotic medication risks probably outweigh their benefit for people who are not yet developed psychosis. I don't know of any, and certainly in the clinical guidelines, that's a pretty consistent recommendation. And it may be that this strategy of doing a finer grained stratification of the samples and finding individuals who have these higher rates of transition would actually justify additional studies of using antipsychotic medication among people who are in the very severe range of clinical high risk to see if it has benefit to be able to reduce that severity to the point where they don't cross the psychosis threshold. But I think those kinds of studies might be possible if you were able to segment the population and identify a group that was at this very, very highest level of risk for imminent onset.
Great, thank you. I'm seeing that Scott is also saying that he doesn't know of any SIPS data longer than 3 to 5 years. I think I heard a reference to a Fusar police study that was done, but it definitely is something that would be worth looking at. And I'm seeing a number of people interested in registering for the learning community, where we'll have lots of opportunities to be sharing all this great research and coordinating with each other. So we will definitely send that information out to everybody. And Tiara, I don't know if there's any additional information about signing up that you might want to provide. So maybe not, but we will definitely send the information to everybody about how to sign up. Tim Ash asked, any comments on how cannabis use enters into the discussion?
Well, I certainly think, so in the studies that have looked at this, substance use is seen as a complicating factor that actually increases both the risk for developing psychosis among people at clinical high risk, and also just complicates their functioning in the community. So I think in most, so for example, in Pat McGorry's clinical staging framework, counseling around substance misuse is one of the elements for people in clinical high-risk states, acknowledging that that use does complicate the course trajectory.
Thank you very much. And I know Barbara Kornblatt also has done quite a bit of looking at cannabis and has some really interesting kind of initial findings around that. So we may ask her to chime in as part of our learning community as well going forward. How about cognition? What do we know about cognition, Bob?
Well, so we know that cognition, that changes in cognition are detectable in the clinical high-risk state. They're actually probably one of the first changes that happened. The work that I mentioned that the Germans have done with basic symptoms would indicate that changes in cognition predate many of the other symptoms of the disorder. So they're there early. And they get worse over time. Measures of cognition are worse in people who may cross over to first episode psychosis than they are in people with clinical high risk. And people with clinical high risk are generally on average, have worse cognitive functioning than others who don't meet the clinical high risk criteria. The data about how to address cognitive functioning, whether cognitive remediation is an effective and viable intervention, I think that there's some very interesting data that about the potential for cognitive remediation training in this group. There do appear to be some implementation issues, as well as both feasibility and acceptability issues for youth in this age category. The work is hard. The cognitive remediation exercises are difficult. They require a commitment, and there have been some reports that is a factor in being able to get people to stick with the program. This probably would be another area where you could have a separate session on this, because there are a lot of differing opinions. I think that it's still an area of tremendous scientific interest. If the kinks can be worked out, it may have tremendous benefit in addressing a key component of emerging psychotic illness, but I'm not convinced today that the data are there that would say we should bring those existing programs to scale. But that would be a great topic for another webinar session.
Yeah, thank you. And one of the things that I heard Gene Addington and Larry Seidman both say was that one of the problems with the research that's been done so far is that it hasn't really specifically targeted people who had cognitive problems. I know On Track New York is actually trying to work on that right now. And then also same thing with functioning, that the studies that have incorporated functional measures have not started with looking at folks who actually need an intervention. They've started with everybody who met the general CHR criteria. So it seems like an area where there's a lot of need for research. So Cheryl Corcoran has weighed in about the cannabis question. Sounds like you've got a lot of knowledge. Prospectively, cannabis use fluctuates with the severity of anxiety and perceptual disturbances in the laboratory. CHR patients who use marijuana have more psychogenic effects than frequent marijuana users who do not have attenuated psychosis symptoms. And within CHR cohorts, cannabis use does not predict psychosis onset, likely because there are many pathways to psychosis. And I know there's some conversation about the difference between the CBD and the THC within marijuana, and that may play a role as well. Interesting conversations. Anything that you would add, Bob, or correct?
I would never correct Cheryl Corcoran.
So we
Again, that's another topic that would really would profit from a whole session itself.
Great.
And particularly, I don't have it in front of me, but with the looking at the new marijuana laws in the various states that are supported through the clinical high-risk program service grants, that might be something that people could look at across the 21 programs, is whether differences in the access to medical marijuana or to marijuana for leisure use are having impacts in both clinical presentation and course for young people who are enrolled in these CHRP programs. That may be another topic for collaborative research consideration.
Yeah. Yeah, I know that Tara Needham just recently from UC Davis was saying that they've had a lot of experiences with high THC use. Like there's certain things like shatter, I guess it's called, that have really high levels of THC that are having a major effect, and we're hearing that anecdotally as well within our program. But they go straight to the first episode, I'm afraid. Yeah. And Cheryl says, CBD has shown efficacy in schizophrenia cohorts in reducing symptom severity. Yeah, so that's a really interesting dichotomy.
Yeah, there was a paper that just came out of that from the Institute of Psychiatry just recently. Phil McGuire and his group showing that effect that Cheryl was mentioning, and indicating that would be a strategy for further investigation.
Right. So we've had a few people inquire about the learning community, and the beauty of this conversation is that we have a number of really amazing experts, and also the opportunity to maintain an ongoing dialogue through an online system where we'll have chat features and the ability to upload webinars and documents. So if this conversation so far is any sign, I think we'll have a really dynamic group. So we will be sending information to the whole collaborative about that webinar, or about that series, and also there is another webinar on February 14th to help get that launched. So let's see, Julie asked, Cheryl, could we request getting the references to the research on marijuana and CBD? So maybe we can just send that out to the whole group. Cheryl, if you could send it to us. We have 7 more minutes, so other questions or suggestions for topics that you'd like to launch into? Sounds like marijuana is one of them.
And it's okay if not. I think that most of these webinars, just for folks to know, will be an hour. We just thought that with this initial webinar, and Bob's talking, has a lot of information about the state of the science and ideas about the future, and sort of pulling people together, that we would make time for an hour and a half. So that's fine. I think that and Cheryl, thank you. Yes, I think it was a nice job, and so I just wanted to tell everyone that if you have any questions or any follow-up issues, please do not hesitate to contact us. We will be putting these together. I think our goal is to ensure that there are resources available for everyone that's doing this work. I want to personally thank Bob and Susan Azrin, both from NIMH, for their amazing work in this and for their incredible collaboration and partnership on these issues. We thank you very, very much. And to the rest of folks, again, if you would like further information, I was joined today on the call by Tanvi Ajmera. Tanvi is one of the leads on the Clinical High Risk for Psychosis grant programs, so you can send either of us information and we can get back to you, or questions or comments, and let us know. Let us know the kind of webinars or information that you'd like for the future, what the best structure format would be that we might, because we'd like to try to figure out some multimodal ways of doing all of this. Thank you, Tanvi, for putting your email up there, and folks should feel free to reach out if necessary. So With that, let me just ask if there's any final comments or questions that folks want to bring up.
I see one question about peer-to-peer, setting up peer-to-peer structures. That'll be something that we follow up on with the learning community going forward.
Great, and we're excited to try out some of our new things on the learning community, like technological advances, and I think that this will be a great opportunity given the interest and the importance of the topic, and also the rapidly growing information in the field. So we thank you. Again, thank you to Bob, thank you to the TA Network, Tamara, for making all this happen and getting us started here on this expanded learning community, and we're